We are going to cover today caring for a surgical patient. So, when we're talking about perioperative nursing, so what this entails is this is the care of the client in all three phases of that operative journey that they may be going through. So, it talks about the preoperative phase, which is before surgery. So, preoperative encompasses the time from the decision to have surgery all the way to the time that they are actually entering that OR suite. Okay, that's your preoperative period. Then there's your intraoperative period, which is the time that they are in that OR suite going through that surgery. And then your postoperative period, which is as soon as that surgery is done, they're exiting that operative suite and going to a PACU, typically the post-anesthesia care unit. Okay. The Association of Perioperative Registered Nurses, what this is, otherwise known as the AORN, this is a highly organized and influential specialty organization within the nursing profession. Okay, the AORN guidelines for perioperative practice are what keeps perioperative nurses up to date on current practices, best practice, things like that. With that, perioperative safety is one of the three domains under which the AORN organizes its perioperative patient outcomes. Specific safety outcomes would include prevention of injury during surgeries and then also freedom from infection. So in the operative world, there's something called never events. So never events are serious and costly errors resulting in severe consequences for the patient, and they are known to be mostly preventable. So believing these events are reasonably preventable and should never happen in a hospital, Medicare actually no longer reimburses institutions for care related to these types of complications. So some of these are super negligent, in my opinion. So surgery on the wrong body part, surgery on the wrong patient, right? These things should never happen. The wrong surgery happening on a patient. These things should never happen, but they do. Human error happens, right? And so those are very serious ones that maybe some steps may have been skipped, like double identifying the patient, things like that. And then you also get into other types of things like just leaving certain operative equipment and sewing it up inside a person, like a draping clip or a sponge or something like that. And then you have things that are known complications of surgery, such as a deep vein thrombosis or a clot in the leg, right? A DVT, otherwise known as, or a pulmonary embolism. We know that going through surgery puts the patient at a higher risk for getting these complications. However, it's known that we know things and ways to prevent these things, such as having the patient wear SCDs or those sequential devices, which we'll talk about in a little bit. And also getting the patient up for early ambulation. All of those things are going to help prevent that DVT, so it is still looked at as a never event. Same with the surgical site infection, especially on bariatric surgery patients. Again, we know that opening the skin and doing surgery is going to put the patient at risk for infection, right? We have them sign a consent that says that they understand that, so we know it can happen. However, it is considered a never event in certain situations. Classification of surgeries. They can be classified in a variety of different ways. So they can be classified by body system. So this is useful for determining the risk for a postoperative infection. For example, incisions that enter the GI tract, respiratory tract, or urinary tracts have a higher risk of infection than does surgery for other body systems. However, if an organ ruptures or surgery is for repair of some kind of like penetrating injury, the risk of infection is very high regardless of what body system is involved. Okay. Other classifications. So the purpose of surgery. So it could be a diagnostic surgery, which is done to confirm or rule out some type of diagnosis. For example, a biopsy or a fine needle aspiration or some type of invasive testing, such as like a cardiac catheterization. So it could be diagnostic, like we talked about, or it could be palliative. So this is performed to relieve discomfort or other disease symptoms without producing a cure to that specific disease. For example, maybe like a nerve root destruction for somebody who's in chronic pain, just to make them comfortable, right? Could be classified by the degree of urgency. So we know emergency surgery is going to require transport to that operative suite as soon as possible to preserve that patient's life or the function of whatever body part we're talking about. There is an urgent surgery, which is scheduled within 24 to 48 hours to alleviate symptoms, repair a body part, or restore function. For instance, removal of a cancerous breast or internal fixation of a fracture would be an example of those. So urgent surgeries they're not as important and pressing as an emergency surgery. It doesn't have to go right now, but does need to go within 24 to 48 hours for urgent. Okay. And then there's elective surgery. So that is performed when surgery is the recommended course of action, but the condition is not necessarily time sensitive. So the client may delay surgery to gather information, consider other options, organize care for their family, et cetera, et cetera. Okay. And then lastly, the degree of risk. So there could be major surgery, which is associated with a high degree of risk. For example, it may be associated with potential for significant blood loss, or it might involve vital organs, or maybe a prolonged or complicated procedure. Maybe it has a significant potential for a postoperative complication or infection or something like that. So that's your major surgery. And then we also have a minor surgery, which is another degree of risk categorization. Minor surgery is often performed on an outpatient basis, involves little risk, and usually has few complications. For example, an arthroscopy, breast biopsy, or like an inguinal hernia repair would be another one. Here is a clicker check for you. So an older woman fell at home and fractured her hip. After being admitted to the hospital, the nurse knows that the patient is to be stabilized prior to having surgery. This surgery would be classified as what? A, urgent, B, elective, C, emergency, or D, palliative. The correct answer is A. So this patient will most likely have her surgery within the next 48 hours. We know that that is an urgent surgery at that point. Must be done to restore that joint function. So we know that there are significant risks going into surgery. Okay, there's some things that can make those risks more apparent in certain populations of people, certain situations. So we want to talk about what are the factors contributing to surgical risk. So first of all, age is a big one, okay? The very young and the very old are at the greatest risk during surgical procedures. So with infants, they have a limited ability to regulate their temperature. That's significant. They have very immature organ systems, immature immune systems, so an increased risk for infection. They have an increased risk for excessive or deficient fluid volume. So some type of electrolyte imbalance or fluid imbalance could be significant. So even a small amount of blood loss can be very significant for an infant. And then on the flip side of that, older adults have less physiological reserves, right? So they don't have that buffer that a lot of maybe middle-aged, spry people may have. They don't have that buffer. So they don't have those reserves, and often they have comorbid conditions. So they're dealing with maybe other conditions like hypertension or obesity or congestive heart failure, something like that, right? So physiologic changes of aging also are going to make that older adult at higher risk for surgery. So these include decreased kidney function. Their kidneys can't filter out the anesthesia or the pain medication as well, which can cause problems. They have diminished immune function, which can increase their risk for infection. They have decreased bone density and lean body mass. They have a decreased cardiac output. So that perfusion piece, they may not be able to perfuse as well if they lose a little bit of blood or even a significant amount of blood during their surgery. They have a decreased cough reflex, which is going to be difficult to cough things up when they have maybe mucus in their throat, and that could sit there and turn into pneumonia or something worse. They also have an increased time required for wound healing, just due to poor perfusion, things like that as well. So that puts those, the very young and the very old, at a significantly increased risk for complications following surgery. The type of wound can also contribute to surgical risk. So both pre-existing wounds, such as from trauma, and also wounds like incisions that are created by the surgical procedure, can both pose a risk for infection. So risk to the patient increases along with the risk for or the presence of infection, right? Presence of infection. Pre-existing conditions, this is a big one as well. So many surgical clients have some type of underlying acute or chronic disorder that may increase their surgical risk. We talked a little bit about that already. So we talked about congestive heart failure, decreased cardiac output, hypertension. Those kinds of things can cause adverse effects during the surgery as well. Mental status. So patients with altered cognition from either physical or mental illness may be unable to comprehend preoperative instructions or unable to give informed consent for surgical procedures, which we'll talk about here in just a little bit. They may also require medications such as antipsychotic agents that may interact with anesthetics or pain medication, analgesics, that are given during that perioperative period. So surgery and anesthesia may aggravate the pre-existing dementia, confusion, and disorientation in these patients. Medications as well can contribute to that surgical risk. So certain herbal and alternative medications specifically can increase the risk for cardiac dysrhythmia secondary to potassium loss, or interfere with the metabolism of anesthetics because of their effect on the liver. It may increase the potential for excessive bleeding, decrease cerebral blood flow, could cause hypertension, increase the effect of opioids, things like that. So, and that's talking a little bit about herbal and alternative medications. You have to make sure that you are assessing what your patient is on, because, there's a lot of people taking supplements, which is great, but they may not understand how that may affect their surgical procedure. So always doing the appropriate interview, finding out what they're taking at home so that you can determine, is there a risk here? Right. And then not only just those herbal and alternative medications, but even prescribed medications that these patients are taking daily from their doctor can increase surgical risk. So such as anticoagulants. So we're talking aspirin, warfarin, and then heparin. Also, these are anticoagulants. What do you think is going to happen if you have a patient who's been taking a blood thinner for a year and then they go into surgery without having stopped that blood thinner? Well, they're gonna have a hard time stopping bleeding, and that's gonna cause a problem, right? So we want to make sure that if they're on those anticoagulants, that they have been off them for the allotted amount of time per their physician before they get that surgical procedure. Diuretics also can cause fluid and electrolyte imbalance. Antibiotics and antidysrhythmics can interfere with anesthesia. These days, a big drug is Ozempic. People are taking that for weight loss, and I know for sure that they've actually seen that slows GI motility, which is how it works, but that also may cause a problem when you have patients who are going in for colonoscopies and maybe it's taken a couple days to do a bowel prep to empty out their bowel in normal patients, but in patients who are taking Ozempic, it may take them 4 or 5 days to actually empty out their bowel. So things like that you want to make sure that you're considering. Personal habits, that's another one. So substance abuse can increase surgical risk. Smoking affects pulmonary lung function. Long-term alcohol use contributes to liver disease, increasing that risk for bleeding. Anytime you're thinking about liver disease, remember the liver has a lot to do with blood and clotting. So we're always thinking bleeding risk when we're talking about damage to the liver. Alcohol and other drugs are going to interact with anesthetic agents and medications to create adverse effects. Habitual substance abusers may also have a cross tolerance to anesthetic or pain medications, causing them to need higher than normal doses. So maybe they've developed a tolerance to a dose that you would give an adult who is opioid naive, and yet this person who's been taking opioids for years and years and abusing them, they may actually be in a significant amount of pain if their dose is not adjusted to what they are used to. And then lastly, allergies. So always keep in mind allergies anytime we're giving medications, and going into the operating room for sure, because we're talking about antibiotics, and we're giving antibiotics a lot in the perioperative period. So patients may be allergic to those medications, those antibiotics, analgesics like codeine, people are allergic to, surgical tape, latex, and then other solutions used in surgery. Betadine, I've seen some allergies to as well. So reactions can range from unpleasant to life-threatening, but we need to be aware of those allergies before we go in. So again, the preoperative phase is the time between deciding to have the surgery until the entry of that OR suite. Okay, your job as a nurse is to prepare that client mentally and physically for surgery. That is our job in the preoperative phase. Okay, few things we need to do. So first, we need to complete a nursing history. So this is going to include the following topics in your preoperative assessment. So we're going to do our health history. We're going to do a mental status evaluation. Is your patient alert and oriented times 3 or 4 or whatever it is? What's their physical status? Are they mobile? What will they need after surgery? Do they need a wheelchair? Will they need a walker? Are there any cultural or spiritual factors? Do they have any allergies? Do they have access to social resources that they may need after surgery? Do they have the coping strategies to get through post-op? Do they have any alcohol or drug use? Are they on any medications, including those herbal products that we talked about? And then what's their knowledge and understanding of the surgery and anesthesia? Okay, it's not our job necessarily to explain any of that, which we'll talk about in a minute about informed consent, but it is our job to make sure that they understand it before they go in. And if they don't, we need to make sure that their questions get answered by the right people. Okay. And then our next thing to do is to do our physical assessment. So if you identify risk factors from the nursing history, we're going to focus on these aspects during our brief head-to-toe assessment. For example, if the patient states that last week they had a cough, we're going to perform a focused assessment on the ear, nose, throat, and the lungs to determine if that cough may affect the patient's risk during surgery, right? And then always we're going to assess the risk for thrombophlebitis. So thrombophlebitis, deep vein thrombosis, DVT, blood clot, all of those things are essentially interchangeable. You can have a blood clot anywhere, but for this particular piece, thrombophlebitis, and anytime you see thrombo, you're thinking clot, okay? Phlebitis is telling you have inflammation of a vessel. So thrombophlebitis, you have a blood clot in your vessel, right? Typically, you're at a higher risk for getting a blood clot in your deep or lower extremities, those veins, post-op. Okay, you're at a high risk for that. But remember, that's one of our never events. So we know how to prevent that. So we just have to be diligent in that. So part of being diligent in preventing that is assessing for the risk at the beginning of surgery, right? All right, another clicker check. So the nurse is completing a preoperative patient assessment. Which finding indicates the greatest risk for development of a postoperative complication? A, the patient is 60 years old. B, the patient's blood pressure is 130/88. C, the patient does not understand the surgery. Or D, the patient has early stage Alzheimer's disease. That is a really tough question. So the answer is actually D. So that surgical experience may exacerbate any type of dementia. Remember, we talked about medications given in surgery. Anesthetics can further confuse them. Pain medication can further confuse them. Even in those early stages, a patient with Alzheimer's disease may not be able to comprehend written or oral directions related to care. In cases of major surgery, the patient with dementia may pull at dressings, drains, IV lines, and be at an increased risk for falls. So another thing we're going to do in the preoperative phase, we are going to do some preoperative screening tests. Typically, you're going to see at least a CBC, or complete blood count, a urinalysis, and an electrocardiogram. So a CBC, or a complete blood count, what that is basically testing for, it's going to show your white blood cell count. It's going to show your red blood cell count. It's going to show your hemoglobin, hematocrit, all of those types of things. Platelets, it's going to give us an overall of the cellular level of that blood count, right? Your UA is going to test to see, do you have an infection already? Are you well hydrated? Things like that. And then your electrocardiogram, that is just going to be your very basic EKG rhythm strip. Can you tolerate surgery, right? Most institutions require a CBC, a UA, and an electrocardiogram for patients older than 50 years old, for sure. But depending on the physician, depending on the surgical procedure, the institution, you will see some combination of these pre-op everywhere, most likely. A routine chest x-ray used to be recommended, but is not recommended for all patients prior to surgery anymore. it's cited that chest radiology incurs extra costs to the healthcare system and exposes patients to small risks from radiation exposure. So they do not recommend that anymore routinely. So here is a very important slide for you to memorize. So this is your introduction to lab values. That being said, I want to preface this little lecture by saying that do you have to have lab values memorized on the job? No, not necessarily. You do not. You don't even really need them on the NCLEX either. They give you reference ranges. However, it is so important to have an idea of a range in your mind because so often are we given verbal report of lab values. So often are we given calls from the lab that we have a critical lab. Or you're given numbers and report. And if you don't understand or have memorized what is at least normal, what is in the normal range, and what kind of symptoms will I see if this patient's lab value in this particular area is out of range, that is the type of critical thinking that you need to have. So I'm a firm believer that you still need to have these somewhat memorized. You'll see more of them. You'll see some of them more than others. Lab values are very different by institution to institution. Every lab has different reference ranges. So the ones that you're going to memorize on this screen for this program will absolutely not match places that you work, for sure. However, for the most part, they will be in general the same-ish range. And then everybody's different. Every hospital is different upon what they treat as too low versus what they treat as too high, all of that. So there is a little bit of discrepancy everywhere that you work, and that's just healthcare. However, memorizing these lab values right here are going to give you a great start to be able to use that critical thinking process and reason through patient presentations symptom-wise, which is really what we need you to do. So you will see test questions on this in this class and in other classes, so I suggest you memorize this screen. So a couple of things I want to go over. So you've got your CBC over here to the left, which we just talked about. Couple highlights of the CBC that I think are important. So your hemoglobin. Remember, your hemoglobin measures the protein molecule in that it is that protein molecule inside the red blood cells that carries oxygen from the lungs to the body tissues. It's going to indicate oxygenation, anemia, blood loss, all that stuff. Hemoglobin, super, super important. It carries that oxygen. If you're when you're checking someone's O2 stat, all that's doing is measuring the hemoglobin in the blood. Okay, that's all it's doing. So if you don't have enough hemoglobin in your blood, your oxygen saturation is not going to be great. They're going to feel super, super tired if their hemoglobin is low. Once you give them a transfusion, they'll be feeling like $1,000,000. Okay, they will also feel short of breath because remember that hemoglobin carries oxygen. So hemoglobin, super, super important. Hematocrit, this is, it measures the proportion of red blood cells in your blood. It's going to also indicate oxygenation. If you're seeing a low hematocrit, you're saying low anemia of some kind, right? White blood cells, this is measuring the amount of white blood cells dissolved in that blood. So this is going to indicate infection. If this number is high, we're saying our patient has an infection of some kind. If it's low, it could mean some kind of immunosuppression. Maybe your patient has HIV. And then platelets. So this is measuring the amount of platelets in the blood. This is going to indicate clotting disorders or bleeding disorders. So if you have a patient that has too many platelets, that's going to put them at an increased risk for clotting, increased risk for DVT. All right. If you have a patient with low platelets, that's going to cause an increased risk for bleeding. So with those patients, we want to make sure that we're monitoring their skin. Do they have excessive bruising? Because that can be a sign of internal bleeding, right? If they have low platelets, do we want to shave them with a straight razor? Probably not. Maybe we should shave them with an electric razor so that they're not at risk to cut themselves. Because if they have low platelets, they're going to have trouble clotting their blood, okay? And then over here to the right, you're going to see, I have it shown here as a CMP or a BMP. You'll see it used interchangeably in different places. So a complete metabolic panel or a basal metabolic panel. This is going to be the lab that's going to test all your electrolytes. So sodium, potassium, calcium, magnesium. It's also going to test chloride, BUN, creatinine, and glucose. So here's your normal ranges here. Sodium, you definitely need to know this, 135 to 145. Potassium, you definitely need to know this, 3.5 to 5. When we're talking about electrolytes, I'm not going to dig deep into this class. You'll learn more about that in Jerome's class. But when you're thinking about sodium, potassium, calcium, magnesium, those are your electrolytes. And what you need to know about that is that they are all going to be very variable based on how poorly or overly hydrated your patient is. Okay. So again, sodium, potassium, super important. Calcium, 8.5 to 10.5. You need to know that. Magnesium, 1.6 to 2.6. Chloride, 97 to 107. When we talk about your blood, urea, nitrogen, or your BUN, this is a kidney function test. Your BUN and your creatinine, which is right underneath that, they go together. They are hand in hand. They are best friends. They are your kidney function tests. Okay. If you see a high BUN and a high creatinine, we know our patient is having kidney trouble for sure. Okay, so these are labs that they'll draw to determine, is there damage to the kidneys? They may also draw this to determine, can this patient tolerate a certain medication that may be hard on the kidneys? And if their BUN and creatinine is high, they may decide to not give that medication because their kidney function is poor. So BUN, kidney function, 10 to 31. And then creatinine, also kidney function, 0.5 to 1.2. And then glucose, just a general here in your textbook, goes by 75 to 110. Again, these can be different elsewhere. I know that I've worked in places where a 31 BUN would be much too high, and I've also worked in places where a glucose was considered normal at 70. So again, there's some variability there, but for the purposes of testing and this program and memorization, this is what I want you to go by. So another big piece of the preoperative period is obtaining informed consent. So surgical consent. Before a surgical procedure is performed, professional standards and the law require the surgeon to obtain the patient's informed consent. Okay, this is an extremely important slide, so please keep your ears open. Informed consent requires that the patient understood the communication that was not coerced or pressured to consent. Okay, so in order for this to happen, there are two important requirements. So first of all, the patient must be alert, rational, mentally competent, and not sedated when they sign. That means they have no pain medication on board. Nobody's sitting there pressuring them to consent. They have to be of rational mind. They can't be like mentally incapacitated, all that. And then the second is that the information must be given to them in a language and vocabulary that they understand. Okay, so if you have a primarily Spanish-speaking individual and you give them a consent in English, that is not informed consent. You have broken one of the two cardinal rules there. Okay, patients who are unconscious or have a cognitive impairment, who have been judged insane or who can't read, write, or hear, and then those under the influence of sedative drugs or alcohol are generally not considered competent to give consent. Okay, an informed consent document includes a few things. So first of all, it includes the type of surgery being performed. It includes the name and the qualifications of the person performing the surgery. So that would mean it's going to include the doctor's name and then also his title, medical doctor, general surgeon, whatever it is. It's going to also include a statement of the benefits and the risks of the surgery, as well as the reasonable alternatives. So here are the benefits of getting this surgery. Here are the risks of getting this surgery. And if you decide not to do that, here's some things that you could do instead that may not help as much, but here is what you can do. This, I repeat, is not the nurse's job to explain these things to the patient. This is the surgeon's job. Okay, but these things are stated on that consent. So that's one of them. Next, the likelihood of achieving those goals is going to be on there. So how likely are they to do this in their recovery? And then also a statement that the patient has the right to refuse the surgery or withdraw their consent at any time. Okay, that's what an informed consent encompasses. Okay. Now, this is important. The surgeon is responsible for three things. They are responsible for giving the patient the necessary information. This includes the risk of the procedures, the benefits of the procedures, the complications they could come into post-op or during the surgery, And then any alternate treatments. So if you choose not to have this surgery, here's some other things that you could do that may not help as much or may help as much, but they are required to present those to them as well. That's the first thing. Second thing, the surgeon is responsible for determining the patient's competence to make an informed decision about the surgery. Okay? And then thirdly, they are responsible for answering any questions until the patient understands. Okay? The nurse is responsible for these following things. First of all, they are responsible for verifying with the patient that the physician has explained the procedure and answered all of their questions. Okay? As a client advocate, that is what we are as nurses. And as a client advocate, it is our job to determine their level of understanding of the procedure, but not to answer their questions. We refer them back to the provider who can answer those questions. We can enforce anything that has already been taught. If the surgeon has already taught these things, we can reinforce that teaching. We cannot ever answer those initial questions. We are also responsible for obtaining the client's signature on the informed consent. This is just verifying that the physician did speak to them and the patient was not coerced and they are competent to sign this document, like we talked about. The nurse is also responsible for witnessing that the client signed the consent. So it was this particular client who signed the consent. It wasn't signed by a family member or a husband or a child. We are also there to witness that they are competent and not coerced to give consent voluntarily. They have to give consent voluntarily. And we're also going to verify that they were informed by the provider. So verify that the client speaks the language that the consent is written in. They cannot sign if they don't speak that language. If we need to, we can obtain a translator, but it has to be a hospital translator, cannot be a family member. Okay? Next, we are also, as nurses, responsible to notify and delay if necessary. So if that patient still has questions, or if you have questions about this patient's competence, you are to notify the surgeon and delay sending that patient to surgery. That is your job. Okay? Next, we are responsible as nurses to document all of these conversations in the medical record. And lastly, we are responsible as nurses to enforce that if the client decides later that they don't want to have the surgery, even after that consent is signed, it is okay. We can notify the surgeon, have the surgery canceled. Okay, the patient, even if they've signed the consent, doesn't mean that they have to continue on with the surgery just because they signed. They can withdraw their consent at any time. Next, we're going to complete preoperative teaching. So preoperative teaching is going to prepare the patient for the surgical experience. It's going to help us ease their fears and decrease the risk of postoperative complications. Because do you think that it's effective to teach someone who just came out of surgery, coming off of general anesthesia, how to tolerate their pain, or how to do an IS, intensive spirometer, or how to do early ambulation? Like, all of these things would not be as effective being taught while the patient is kind of loopy coming out of surgery, right? So we want to teach them what to expect before they ever go back there. So when we're talking about the teaching, the content of that teaching plan should focus on a few things. So what will happen before, during, and after surgery, how the patient or the caregiver, if you're discussing a child perhaps, can participate in their care, common feelings and concerns that patients have about that particular surgery. That's going to help the patient feel supported and less anxious. When patients and families what patients and families can do to prevent surgical site infections and decrease the risk of postoperative complications. So again, we can do this with a discussion. We can face-to-face chat these things out. We can use printed materials. We can talk about, we can show videos if we need to. We can do it kind of however we need to. But that preoperative teaching is vital that it happens before the surgery. We want to make sure that they know what to expect during their recovery period, but also we want to kind of start that discharge planning as well. What kind of resources do they need when they go home? So again, we can use written instructions, videos, phone contact, face-to-face discussion, however we want to do it, but that's going to provide our preoperative teaching. So always important to provide that teaching in a language that the patient understands, okay? Again, and also at the appropriate cognitive level so that it can be easily understood by your patient. If you're talking to a teenager, we need to adjust how we're going to talk. If we're talking to a child, we need to adjust that so that they understand. We want to avoid medical jargon, okay? We don't want to talk to them and tell them everything using medical terminology that they may not understand. We want to talk to them in a way that is very general talk that they will understand and be able to apply this information to their recovery. When we're talking about children, super important, probably a priority intervention here with children is to include their family members in the teaching as much as humanly possible, okay? Especially if it's a young child, but also a dependent adult. So if they have a caregiver of any kind, that is a priority to include their caregiver into the plan of care as much as humanly possible. For children, play is a very effective way for children to learn. So if the child had a doll, have them give medicine to their doll with an empty syringe, or listen to their doll's heart with a stethoscope. Simple language is a must for these kiddos. For example, you would say to a young child, lie on your tummy, please. Something that they would understand that puts them at ease. Again, including parents and caregivers is just a pillar for caring for children. We also want to keep in mind, like I said, the developmental level of the child that we're speaking to. Very young children live in the here and now, and they have a hard time visualizing the concept of what may happen in the future. So it wouldn't be effective to tell them, hey, your throat is really going to hurt tomorrow after this tonsillectomy, because they don't have the concept of understanding that their pain could occur in the future. So that is, and then also paying attention to the certain kinds of complications that may arise from whatever procedure they're having. For example, if they are having a tonsillectomy, a huge postoperative complication that we're always on the lookout for with tonsillectomies is bleeding risk. So always paying attention to that post-op bleeding, only allowing liquid or soft foods for the first 24 hours, things like that. And then when we're talking about older adults and teaching them, again, they may experience physical, psychological, or psychosocial issues that impair their ability to learn. They may have decreased hearing or decreased vision or a decreased sense of touch. And that may interfere with their ability to understand and remember information. So to increase understanding, let's provide an environment that's conducive to learning, allow for more time for the patient to process information, and provide written materials that conveys the essentials that they can reflect back on later. Also, keep in mind, remember when we talk about delegating, we only delegate we can't delegate what we can eat, right? So evaluate, assess, or teach. So we cannot delegate teaching to an unlicensed assistive personnel, and we're also not going to delegate that to an LPN either. That is our job. So right before we are taking our patient into surgery, we are going to prepare them physically, okay, for the operation. So maintain normothermia. A lot of things that happen in the OR is going to just inherently decrease the body temperature. It's a cold room so that we can keep bacteria from not thriving in there, right? And so that's a huge concern, is the normothermia in our patients. So hypothermic patients have more frequent wound infections, cardiac complications, blood transfusions. Hypothermic patients feel uncomfortable. Shivering is going to raise oxygen consumption. So remember, and we could talk about that a lot when we talk about newborns who undergo cold stress, okay? So when your body is too cold, your oxygen consumption is going to raise by 40%. So we have to keep an eye on temperature and do active pre-warming before the induction of general anesthesia to help prevent hypothermia. General anesthesia is going to cause a degree of hypothermia, so we have to combat that. So that's when you may see bear huggers with temperatures that are low after operations and things like that. So they'll warm the IV fluids that go into the arm, things like that. So we always need to be thinking about temperature during that operative process, but also before, so that they have a good buffer, and then after as well, so that we make sure that they're recovering the way that they should be temperature-wise. Assess the NPO status. So remember, NPO just means nothing by mouth, right? So to decrease the risk of nausea and vomiting, patients usually fast from food and liquids for about 8 hours before surgery. They do this typically to prevent aspiration. So if they were to throw up during their operation as they're lying flat on their back and they're vented, they could easily aspirate whatever vomit that they may throw up, and then could cause that postoperative complication of pneumonia. So we want to make sure that they've been NPO for as long as they were ordered to be NPO. We're going to prepare their skin. So a surgical scrub, depending on the surgery and the facility, patients may be asked to shower or scrub the surgical site with soap or an antibacterial solution or chlorhexidine, betadine in some situations. They may be asked to do that at home the evening before surgery and in the morning of surgery. So studies demonstrate that this reduces bacterial colonization on the skin. For that. So a lot of times you'll see that. And then when they go in for a particular procedure, for instance, when I was in C-sections in the OR, we would always do a sterile scrub of the belly right where that incision was going to be made. They would have already had their chlorhexidine bath, and then we just did that additionally. And then ensure bowel preparation. So enemas are used primarily for surgical procedures of the colon, not for all surgeries. So if they're having some kind of GI surgery where they need their bowel to be evacuated, we just want to make sure that we're paying attention that that is done. So typically for these patients who are required to have this done, to empty the colon of feces, the patient's asked to consume a low residue diet for several days before the surgery, and then they're given a regimen of medications or enemas to clear the bowel. It's important for us to reinforce that teaching and stress the importance of adhering to that regimen to limit the risk of contaminating the operative site with feces. That would not be good, right? Facilitate an empty bladder. So indwelling urinary catheters are not necessarily routinely inserted for surgeries, but there are a lot of surgeries where they do put them in, especially if after surgery there is a need for post-operative strict intake and output. So catheterization may be prescribed if it's important to keep the bladder empty during surgery as well. So for instance, when I would do C-sections, they want to make sure that the bladder is empty and not filled with urine because they don't want to accidentally cut into the bladder instead of the uterus. So they want that bladder to be small and out of the way. So we always put in a Foley when the patients come in to have a C-section. And again, other reasons for that would be if they're on strict I&O afterwards, if their fluid status is being carefully monitored, or if their surgery is expected to last for a super long period of time. So if they're doing 8 or 9 hour surgery and we don't put a Foley in during that operation, we are potentially putting them at an increased risk for UTI, and that would stretch their bladder to the point that it may rupture depending on how much fluid is contained in there. So that's important as well. Also, another job of ours to administer preoperative medication. So the anesthesiologist may prescribe something preoperative to relax the patient. It may be something to reduce their respiratory secretions. They may prescribe something to reduce the risk of vomiting or aspiration. If the surgery time is known, then usually the medication is prescribed at a prearranged time. But if not, you may have to give it on call whenever the surgeon tells you to. Or sometimes we give it like on the way back to the OR as well. And then again, back to our never event of the DVT, we're going to be required to apply anti-embolism stocking. So we are talking about either TED hose or SCDs, okay, or sequential compression devices, SCDs. Okay, so when we're talking about TED hose or anti-embolism stockings, these are elastic stockings that compress the veins of the legs and increase venous return to the heart. So I want you to understand what that means. Don't just hear me say words. I want you to understand what that means. So these are tight, elastic stockings that compress or tighten, right? Put pressure on the veins of the legs to increase venous return. So to help the blood in the legs propel upwards back to the heart, okay? Remember, we talked about gravity. If our legs are hanging down, it's harder and harder to work against gravity for our legs. So we want to prevent the pooling of that blood in our lower extremities, because what happens when our blood pools and it's not moving? It clots. And what is our never event for post-op? a DVT, right? Which will happen if we don't try to prevent it, or can happen, which is high risk for happening. So we apply these anti-embolism stockings or TED hose, right? They may be applied preoperatively to prevent that venous pooling during the surgery and decrease that thrombus or clot formation. And then also an alternative to that as well is those SCDs, sequential compression devices. So that's those little leg jackets, essentially. Put the little cuffs on their legs and hook them up to a machine, and it will periodically inflate and squeeze their leg to promote that venous return, shoots that blood, assists with shooting that blood up towards the heart, assists with that venous return. And then it will release, and then it will compress, and then it will release. And so a lot of times those are put on before surgery, and they're going during surgery, and we keep them on after surgery for a certain amount of time. And so our last little bit of responsibilities in our preoperative nursing phase. So we are going to take measures to prevent the wrong patient, wrong site, wrong surgery, some more of our never events, right? And how we're going to do this is we're going to use a preoperative checklist to confirm that the appropriate documents are available and the appropriate activities have been performed before the patient gets into that operative suite. We're going to verify the patient's identity before the patient leaves the preoperative area. We're going to mark the surgical site before surgery. We don't typically do that. Typically, the surgeon will do that. But we're going to make sure that they are marked before surgery. And then we're going to take a timeout with all team members before starting the procedure. So we'll talk about the timeout here in just a moment. And then we're also going to communicate with the surgical team. So the most common root cause of medical errors is a communication failure. So for this reason, good communication is essential for patient safety in perioperative care. For successful communications, the surgical team members must receive a summary of the plan of care. So a short brief about the patient's position and what has happened up to this point, and then an understanding of the plan of care by all team members that are involved. You need to speak up and be assertive with concerns about the procedure or the decisions. You need to ask questions to clarify confusion. You need to acknowledge that you have heard and understood, and that they have heard and understood anything that you have said. You need to ask for and provide feedback on critical information. Use standard terminology. Or only approved abbreviations, identify topics that could be discussed or should be discussed in preoperative teaching. And at this point, we're going to transfer the patient to the operative suite. So once you've completed your preoperative care, the patient's ready for transport by stretcher, or sometimes they can even walk there depending on what surgery we're talking about. And then we're going to give our preoperative checklist and the patient's chart to the people intaking them in the surgical suite. We're going to make sure that if the patient had any valuables, that those get locked up according to your agency policy. And then we're going to make sure that we take away anything that is extra on them. So any jewelry, a lot of surgeons or anesthesiologists will not let patients wear even earrings, nose rings, anything like that, because they're at a risk for burns due to some of the equipment that they use back there. So glasses they can't have, hearing aids they can't have. If they have dentures, those need to be out. Any type of prosthetic teeth at all, because when they're intubating them, that can cause a choking hazard, or they can get broken, things like that. So we need to have all that stuff. And then while the patient is in the intraoperative suite, we need to prepare the postoperative room for them for when they come back. So inside the intraoperative room, typically you're going to see a few different people. We have the sterile team. Okay, so the sterile team includes the surgeon, the surgical assistant, and then a scrub person. So before beginning the surgery, they perform a surgical scrub of the hands and arms. They're going to dry with sterile towels. They're going to don their sterile gowns and don their sterile gloves as well. So they are sterile. So they cannot touch anything that is not sterile from the time that they scrub in to the time that they scrub out. You're also going to have the clean team. So team members who abide by a clean technique or medical asepsis is going to include the anesthesiologist. So they are not sterile. also the circulating RN that may be in there. They're not sterile either. Biomedical technicians may be in there, radiology techs, things like that. These people never really enter the sterile field, but instead they function around the field and beyond it. So if the surgeon needs something sterile placed on his table, that would be the job of the circulating RN to open that package and sterilely let it drop onto their field. So they're kind of an extra set of hands for the dirty things that the sterile people cannot touch. You're also going to have anesthesia in the room. So an anesthesiologist or a CRNA, certified registered nurse anesthetist, is going to induce amnesia, analgesia, which is pain control, and muscle relaxation or paralysis with the anesthesia. So their role is to continuously monitor and evaluate the patient's responses to the anesthetic agent and to the surgical procedure. So CRNAs administer more than half of all anesthetics in the United States, and interestingly enough. And then skin preparation. So depending on the surgery and the facility, again, depending on what it is, they may have done a surgical scrub before. We may be required to do that, and now would be the time to do that. Positioning. So we want to make sure that they are positioned appropriately, determined on what site is being operated on, things like that. So 5 variables determine the position of the patient in the operating room. So the surgical site, access to the patient's airway, the need to monitor vital signs, comfort, and also safety. So a position that is ideal for accessing the surgical site may not be used if any of those other factors are going to be compromised by that position. So if the patient has some kind of pre-existing injury or discomfort, that's going to be factoring into this decision as well. There are multiple types of anesthesia. So when we talk about general anesthesia, this is going to produce rapid unconsciousness and a loss of sensation. So the anesthesiologist or nurse anesthetist is going to administer inhaled or IV medications that depress that patient's central nervous system and relax their muscles. So muscle relaxants, paralyzing agents, narcotics, barbiturates, and inhaled gases are some of the agents that may be used during general anesthesia. This is you go to sleep and then you wake up when it's over and you remember absolutely nothing. Patients need to be breathed for at that point, so they're vented, and the CRNA or the anesthesiologist is controlling the respirations with the equipment. Then there's conscious sedation. So this provides IV sedation and analgesia, so pain control, without producing unconsciousness. So during conscious sedation, the patient may feel sleepy, but is aware of their surroundings, can be easily aroused by touch or speech, and can talk with the surgical team. Because of the amnesia-like effect of many of these medications, the patient may not recall certain aspects of the procedure afterwards. Conscious sedation is typically used for procedures such as a bronchoscopy or cosmetic surgery or a colonoscopy as well. Then there's regional anesthesia. So this is going to prevent pain by interrupting nerve impulses to and from the area of the procedure. So the patient remains alert, but is numb in whatever area is being provided that regional anesthesia. So it may be administered by infiltration of the surgical site and the surrounding tissue with the local anesthetic, such as lidocaine. Those medications may also be injected into or around specific nerves to depress the sensory, motor, and or like sympathetic impulses of a limited area of the body. So regional, limited area there. Okay. And then your local anesthesia. This is going to produce a loss of pain sensation at the desired site. So it is typically used for minor procedures. However, after finishing major surgery, the surgeon may infiltrate the operative area with a local anesthetic to provide some form of postoperative pain relief. So local anesthetics may be applied topically or injected. A topical anesthetic is applied directly to the skin and the mucous membranes. Lidocaine is commonly used because they are rapidly absorbed and also rapidly acting. So a surgical timeout, this is the final verification, okay? This is where we prevent all of those never events, or a lot of them at least. So this is one of the safety steps to verify the correct patient, the correct surgical procedure, the correct operative body part, those kinds of things. So We always, always, always verify the client, the procedure, and the site. With that, typically you'll see one person that will say, we're providing a whatever procedure on this particular patient. They'll be reading from the chart, and then everybody must say that they agree. Everybody has to stop what they're doing when they call timeout, so that everybody can pay super close attention. If the patient is still awake at this time, they can also verify this stuff as well. I know that when I was working in the OR before they started, the patients are awake during the C-section. So I would say, what is your name? And they would tell me, or what is your date of birth? Do you have any allergies? And the patient would actually participate in our timeout. It's not always like that. However, if they can, it's just another person that can verify that you're doing the right procedure on the right patient. Couple other things that's super important for client safety in the operating room. Sterile field. So maintaining a sterile field, super, super, super important. Clean to clean, dirty to dirty. You have to make sure that you're meticulous in maintaining your sterile field. Monitoring intake and output. So together with the anesthesiologist, that circulating nurse is going to monitor the fluid that's infused, the urinary output that's draining, any drainage from drains or suction. Maybe they're suctioning blood out of whatever area they're operating on, and then also monitoring any blood loss. Another job for that circulating nurse and the scrub nurse is to count the material that is added to the sterile field. So if the scrub people start with 10 gauzes on their table, but they use them all and they need 5 more, you are the one who adds them. You'd never add 5 at a time, but you may add 1 at a time. And then as you add them, you have to count them, because then at the end we have to make sure that we have the same amount. We have to make sure that we have 15 used sponges and that we don't have 14 used sponges and 1 gets lost inside the patient, right? So sponges, sharps, and instrumentation count is extremely vital. So you usually have 2 people that are verifying those counts, typically your circulating nurse and then your scrub tech. And then documentation, super, super important. We're going to record all the care that's provided. We're going to record all the sponge counts, sterile procedure, output, all that stuff. If you go to the actual PowerPoint, you will be able to watch this video. It won't play on this screen of the PowerPoint. However, I highly suggest you go watch this video. It's very good surgical timeout. All right, so the nurse knows that the following should be given highest priority when receiving a patient in the operating room. So A, assess the level of consciousness. B, verify patient identification and informed consent. C, assess the vital signs. Or D, check for jewelry, glasses, and dentures. And the answer is B. Keep in mind verifying the correct patient and identity, birthday, procedure, all of that is going to prevent that general harm from those never events, okay? It's the nurse's job to correctly identify the patient, ensuring that the informed consent is signed prior to the onset of that surgical procedure. And then lastly, we are moving to that post-operative care phase, or the post-anesthesia phase, it's also known as. This phase is going to begin when the client is transferred from that operating table to a bed or a gurney, and then they transport that patient to the PACU. Some places work a little bit different. A lot of just general surgery patients are going, like I said, just straight to a PACU. I know that we had a surgical suite in OB on our own floor, and so we didn't have a PACU, but our C-section moms would come back to their room, and then a dedicated OR nurse, so not the OB nurse, would actually recover them for the first hour or so, and then would transfer care back to the L&D nurse. During this phase, the patient is at a high risk for respiratory and cardiovascular compromise. Okay, these patients are coming off of anesthesia. Remember, when they're under that general anesthesia, it's going to affect their respiration. So they're not going to have that drive to breathe. They're vented and being breathed for typically in the OR, depending on the type of anesthesia that's used. But those types of things are what's going to put them at a higher risk for that respiratory and cardiovascular compromise early in this stage. So as a precaution, as they're being transported out, the anesthesiologist and the circulating nurse are going to accompany that client and then attend to their needs during the transport to the PACU. those two people are also responsible for giving a comprehensive report, handoff report, to the PACU nurse as they get there. So our big things that we need to understand that are part of our job during this post-operative care phase. Again, recovery from anesthesia. That involves assessing the airway, making sure circulation is going correctly, things like that. So when we talk about airway management, they've got a lot of drugs on board that affect their ability to breathe. So we want to make sure that they are coming off of that appropriately. We want to make sure that we are assessing the respiratory system often. So talking about continuous O2 monitoring, checking respirations, checking color, making sure they're not cyanotic, things like that. Work of breathing, shortness of breath, all of that kind of stuff. We want to make sure that we are managing that. Once they're kind of out of that general, they're awake, they're breathing on their own, their respiratory system is stable, we want to make sure that post-operatively we are focusing on making sure that they keep that respiratory function. So we know that if people lay in bed or post-op, people are at high risk for getting atelectasis, which is a collapse of those alveolar sacs in the lungs, which can lead to pneumonia, trouble breathing, all of those kinds of things. So most postoperative patients are given an incentive spirometry to facilitate deep breathing. It increases lung volume. It promotes coughing, which clears the mucus from the respiratory tree. And we'll talk a little bit more about that. I'll show you some pictures here in a little bit, but that's a big thing with airway management post-op. Next, we're going to be doing a focused physical assessment. So we're not going to be doing the whole head to toe. We're probably not going to be checking their head for lice because that's not important in this moment. We're going to focus on the things that are important. So we know that post-operatively they have a risk for cardiovascular and respiratory compromise. So we're going to do assessments focused in that area. In addition, we know that anesthesia slows bowel motility, so we want to make sure that their bowel sounds come back. It is normal in the early postoperative period for patients to not have any bowel sounds, to have absent bowel sounds. However, those should start to come back, and if they don't, that could signal a very significant postoperative complication. So, and we'll talk a little bit about that in a minute, but focusing our physical assessments is important. Taking vital signs on a routine basis. So all facilities are going to have something different with how frequently you need to check these, but typically it's staggered. So maybe every 5 to 15 minutes in the early postoperative period, and then it will eventually stagger out to maybe every hour, then to every couple hours, then to every 4. It just depends on where you work. And then pieced in with that vital signs is going to be the level of consciousness. So when the patient is first transferred to PACU, they're probably unconscious, probably haven't woken up yet. So documenting that early in that period, and then also continuing to assess that and document that so that it's noted when the patient actually does wake up. Are they confused when they first wake up? When do they kind of come to and understand? Those kinds of things are important to follow up on. Addressing assessment and assessing the drainage. So depending on where their incision is, what kind of operation that they had, we want to make sure that we are always assessing that dressing. So keep in mind, bright red frank bleeding, that is like an increased amount, signals active bleeding. Is some drainage expected? Absolutely. A lot of times it will seep out over time, though. Typically, if you're seeing a lot of drainage on something that's sutured or stapled closed, that can signal something. So we just want to make sure that we are identifying changes. So if a patient comes back with a dressing that's completely dry, and then you look at it 5 minutes later and it's completely saturated in bright red frank blood, we have a problem, right? So really assessing for changes and patterns and things like that, super, super, super important. Fluid therapy, patients will be on IV fluids. That will come order by order, so we just want to make sure that we're maintaining those lines as ordered. And then pain control, that is super, super important in the postoperative period. As the patient starts to wake up and recover, their pain will come at some point. They'll probably be feeling pretty good there for a minute while their pain medication is still working, and then it's going to wear off. So a lot of places will have a protocol in place where they are given a certain combination of medication even while they're not in pain. So early on in that postoperative period, where their IV pain medication that they got during surgery is probably still working, so they're not in pain. But then we may give them something additional to kind of cover them for when that surgical medication starts to wear off. So staying ahead of that pain postoperatively is so important, because if all that stuff just kind of, that medication just stops working as it kind of goes out of their system, the patient is going to be in an extreme amount of pain, and catching up to that pain to get your patient comfortable again is a real challenge. So making sure that we are administering that medication as ordered is important. The next few slides here are going to go over some very common post-operative complications that we need to be on the lookout for as that post-operative nurse. You need to know all of them, so please pay special attention to these slides. So I'm not going to read all of this to you, but I'm going to hit the cliff notes here, so just make sure that you review these tables in your book as well. Aspiration pneumonia. Keep in mind, anytime a patient is getting anesthesia, it completely decreases their gag reflex. Okay, this puts them at an increased risk for aspiration. So should they aspirate, and remember that just means that something, food, fluid, gastric secretion, something is going into that lung and sitting there causing infection. Okay, so some symptoms we're going to look for: cough is a big one, a wet cough. A fever, which is going to signal that we have an infection. Elevated white blood cell counts, which we talked about, that is going to signal that we have an infection, right? Decreased or absent breath sounds, decreased oxygen saturation. Tachypnea, which remember means an increased respiratory rate. Dyspnea, which means shortness of breath. And then blood-tinged sputum as well. And some interventions for this. That's why we put our patients on that NPO diet before surgery, so that this doesn't happen. It decreases the risk of that happening. And then we're going to continue that NPO status until intestinal motility returns. So once their bowel sounds come back, then we can maybe talk about advancing their diet. But if they're not having bowel sounds, then we're going to keep them NPO, right? And then also we're going to make sure that we closely monitor patients that are in a side-lying position. Place them in a side-lying position, because we want to make sure that, like we talked about with oral care for the unconscious patient, anytime you have a patient with an absent gag reflex or that's high risk for aspiration pneumonia that may not have control of those functions, side-lying is going to help those secretions kind of roll out of the side of the mouth. Another huge complication, so atelectasis, which is, like we said, collapse of the alveoli, due to hypoventilation, airways that may be blocked by mucus plugs, pain medication, immobility, all these kinds of things, a very well-known postoperative complication. So signs and symptoms, big one. A big sign and symptom of atelectasis is going to be decreased or absent breath sounds, especially in the bases of the lungs, okay? That's a huge one. Noisy respirations you may see, decreased O2 sats, sternal retractions, those signs of respiratory distress, nasal flaring, accessory muscle use, those kinds of things. Fever can even be one as well for atelectasis. So that's a big one. Things that we're going to do to prevent or treat as we see that it may be an issue. Monitor for those clinical signs like we just talked about. Monitor and assess for respiratory function. So the rhythm, the depth, the effort of their respirations. See if they can cough effectively. A lot of times this can just be that they don't cough, which is why we promote that deep breathing and coughing. That's what's going to inflate those lungs that have collapsed. If they need suction, we're going to suction them. And then again, encouraging deep breathing and coughing, moving around in bed, early ambulation, and the use of that incentive spirometer, which again, we'll go over here in a few slides. And then the last couple, so pneumonia, inflammation of that alveoli, another infection. We're going to see productive cough, possibly blood-tinged or purulent sputum. Purulent just means infected, pus-like. They'll have a fever because they have an infection, which brings along the elevated white blood cell count, those kinds of things. So again, that's going to be very similar in treatment to that aspiration pneumonia. And then lastly on this slide, pulmonary embolus. So this is going to be a clot that occludes blood flow to a portion of the lungs. Okay. A lot of times this is a big complication of an untreated DVT, or that deep vein thrombosis, right? That blood clot in the leg. If it becomes mobile and starts to flow through the circulatory system and goes into the lungs, now you have a pulmonary embolus. Okay. Your big cardinal signs of your pulmonary embolus is going to be sudden onset dyspnea. So your patient is very suddenly shortness of breath. They are having chest pain, their blood pressure is low, they have a super high heart rate, and then decreased O2 sat. A hemorrhage. So remember, anytime we're talking about a hemorrhage, we're talking about excessive bleeding. So this bleeding may be internal or it may be external. So it can be caused by anything. If you have uncontrolled bleeder, maybe somebody who is on significant anticoagulants that we let get surgery anyway, which would not be good. Could be caused by the surgeon nicked something during surgery that they didn't intend. Could be caused by infection as well. Clinical signs. So if it's an external bleeding, remember that just means we can see that with our eyeballs. So we're going to see dressings that are saturated with bright red frank bleeding. We're going to see an increase in output in any type of drain that they may have, or chest tube as well. If it's an internal bleed, this is going to be something we can't really see with our eyes, so we don't see the physical bleeding, but we will see an increase in pain in our patient. We may see an increase in abdominal girth. So maybe if they had abdominal surgery and we start to see their abdomen swell, that's a red flag, because it could be filling with blood from a nick that maybe the provider didn't know that they did. Ecchymosis, that just means bruising. That's something that we can see with our eyes. That just means there's bleeding under the skin. So we would maybe monitor that bruising, draw a little circle around it, see if it gets bigger, those kinds of things. Swelling around the incision, and then tachycardia and hypotension. So one thing I kind of want you to understand and always correlate together. Anytime you have a patient who is hemorrhaging or losing a lot of blood in a small amount of time, what happens when your circulatory system loses a lot of blood? Well, your blood pressure is going to tank, right? You're going to have hypotension. Your body's compensatory mechanism to low blood pressure, it wants to increase the blood pressure, and it's going to do that by increasing the heart rate so that it can continue to get that blood out faster and quicker. So it's pumping harder, pumping faster so that it can get that blood out where it needs to go. So anytime you're having hypotension, you're going to have tachycardia with that as your body tries to compensate. Eventually, the heart will get tired and it will turn into bradycardia if that bleed is not stopped, and that's when patients start to take a turn for the worse, right? But anytime you're seeing bleeding with hypotension and tachycardia, there is a bleed somewhere. You're losing volume, or there's not enough volume or something. That's a compensatory response. And then hypovolemia, so this just means decreased blood volume. So it could be due to blood loss during surgery. So if you have a hemorrhage, you're going to experience hypovolemia, low blood volume, right? Could be from starting with dehydration or an excess loss of fluids through vomiting, diarrhea, or even drains. And again, those symptoms are going to be the same as that massive hemorrhage. So hypotension, tachycardia. And then also hypovolemia, you're going to see decreased urine output. Remember this, your kidneys need blood perfusion in order to produce urine. So that's why checking output is so important to let us know, are we perfusing correctly? Because if we stop producing urine, that tells us that we don't have enough blood volume to get perfusion to the kidneys, so the kidneys can't function, okay? These patients may also have fatigue. They'll be very tired, right? Because they don't have that hemoglobin. They don't have those red blood cells carrying the oxygen and nutrients to their cells. And they may be very thirsty because they don't have a lot of fluid in there. And that's their body's way of saying, give me more fluid, give me more fluid. Some interventions for this. Obviously, if you have an active bleed, pressure is going to help stop that bleeding. Frequently monitoring vital signs and dressings and wound drainage. For your hypovolemia patients, strict INOs so that we know, are those kidneys being perfused. Monitoring skin color, temperature, moistness, central and peripheral cyanosis. And then administering any type of therapy as prescribed, promoting oral intake as it's tolerated. All of this is going to depend on the presentation of your patient. And then eventually, should it be bad enough, you may need to administer blood products as well. So next, we're going to talk about constipation. So this is a postoperative complication too. This is going to be a decrease in the frequency of bowel movements, resulting in the passage of hard stool. Remember, giving opioids, which they probably got during surgery, that's going to contribute to this. Also, immobility. So our post-op patients are immobile for a time, right? Inadequate fluid intake. So your patients that went in for surgery, they've been in NPO for some time and they can't really take in PO fluids until their GI system starts working again. And then also another contributing factor could be a low fiber diet as well for constipation, as we know. But what I want to stress is that we do a lot of things during surgery that's going to contribute to this constipation. So we need to be on the lookout for this. So clinical signs, we know abdominal discomfort, bloating, hypoactive or absent bowel sounds. Interventions for us that we're going to do, encourage and assist the patient to move in bed. Early ambulation, early ambulation, early ambulation. We're going to increase their fluids and increase their fiber intake as well. And then constipation, or the next thing we're talking about is a paralytic ileus. So this could be another postoperative complication. This is the loss of forward flow of the intestinal contents due to decreased peristalsis secondary to anesthesia. Remember, when we're giving anesthesia, it's going to slow down or cease that peristalsis, that normal movement of your bowel. A lot of times during abdominal surgeries, if the doctor is touching the intestines also, that can cause a paralytic ileus. It will cause the bowel to not work properly. And our job as postoperative nurses is to make sure that that function comes back. So with the paralytic ileus, we may see abdominal pain, abdominal distension, absent bowel sounds, vomiting, those kinds of things. Okay. This is an emergency. So if we notice that they're having any of these symptoms, or that maybe they've gone a certain amount of time without bowel sounds after surgery, this is something that the surgeon needs to know immediately. Surgical incision complications. So dehiscence, this is going to be a separation of one or more layers of the wound due to poor nutritional status, obesity, other straining on that suture line, any inadequate closure of the muscles, a wound infection, anything like that. Clinical signs and symptoms we're going to see, patient will typically complain of a pop or a tearing sensation, especially when they are doing something that's going to increase that intra-abdominal pressure. So if they're straining for a bowel movement or coughing or throwing up, changing positions in bed, usually there's an immediate increase from that incision site in serous sanguineous drainage. And that's what we're going to see. So interventions for this, provide that adequate nutrition to prevent this, using binders to support that incision, and making sure that the patient knows, hey, I'm going to split my incision when I'm coughing, throwing up, doing anything that increases that intra-abdominal pressure. Have them avoid straining best that they can, and then monitor for infection as well. And then we remember from our skin chapter that evisceration is going to actually be a protrusion of organs or tissue through that separated incision. Same signs, clinical signs and symptoms as a dehiscence, aside from the fact that we're actually going to be able to visually see some type of organ through this incision. And then same preventative measures as with your dehiscence patients. And then a wound infection. So again, what's that? Inflammation or drainage from a wound due to the growth of microorganisms. We're going to see localized swelling. We're going to see redness around the wound or the incision. It's going to feel warm. They're going to have pain. They may have a fever. Remember, a fever is considered anything at or above 100.4 degrees Fahrenheit. They may have a foul-smelling discharge coming from the wound, or there may be a change in the color of the drainage as well. So prevention and early detection, effective skin prep in the postoperative period, surgical scrubs, like we told them, that chlorhexidine wash, doing our surgical site prep, things like that. Monitoring for those signs and symptoms of infection, inspecting that incision and assessing it often per our facility policy, monitoring vital signs, especially temperature. Limiting the number of visitors to the room as appropriate. A lot of times there is no restrictions for that, but just kind of keeping that in mind, making sure that the patient is increasing their oral intake. So what is the big nutrient that's going to help us with wound healing? it's protein. So we want to make sure that they're intaking a lot of protein to assist with that healing process. And then teaching our client about signs and symptoms of infection as well, so that they can follow up should they notice something. And then lastly, thrombophlebitis, which we've talked about briefly throughout this whole PowerPoint. This is a big one. Remember, this is one of our never events. So this is a blood clot or inflammation of a vein or artery, usually in the legs, resulting from increased coagulability, venous stasis. Contributing factors is going to be your immobility during and after surgery, right? So this is your DVT, your thrombophlebitis, deep vein thrombosis, blood clot in the leg, whatever you want to say. All the same thing, never event, can be prevented, and that is our job, okay? Clinical signs and symptoms you're going to see. You will see a vein that is red, hard, hot or warm to the touch. If it's getting super significant, you may see that the limb, like whichever leg, is pale, may be edematous or very swollen. They may feel an aching, cramping sign in the limbs. And then they also may be positive for Hohenstein, which actually Hohenstein isn't used clinically much anymore, but it is still written about in your book. A Hohenstein is when a nurse will take the patient's leg if they suspect a blood clot. And if they dorsiflex the foot, so they push that top of the foot back towards the ankle so that the foot is flexed, the patient would feel pain in their calf, and that would be a positive Hohenstein, would suggest that maybe they have a blood clot in the leg. Big thing when we're talking about thrombophlebitis or DVT, do not massage these legs. And that is one of the reasons that they don't even recommend the Hohenstein anymore. If your patient has thrombophlebitis or you think they have a clot, we don't want to massage or really maneuver that leg in any way. We want to immobilize that limb, because what happens if we do something that causes that clot to dislodge? Now it's flowing right to the lungs, and they're going to end up with a pulmonary embolus or a PE. So immobilize that limb, super important. And here's a couple pictures of two patients that actually have a DVT. So with this, you can kind of see that what is the most helpful when you're assessing is comparing one leg to the other, right? So if you look here to your picture on the left, you can see that this patient's left leg, if you look at it by itself, it might not look so horribly bad, but if you look at it compared to the guy's other leg, you can see that it is swollen, it's a little more red in color, and this patient has a DVT in that left leg. If you look here on the picture to your right, same thing, we're comparing side to side, and we can see that this patient has a very red discoloration on that right leg. It is more swollen. You can kind of see the red streaking in that right leg. All of this pointing to a DVT. So with those DVTs, DVT prevention, we are going to talk a little bit more about the sequential compression devices. So again, this is pretty standard in all hospitals now and just put on pretty routinely for a lot of patients. So remember, this is those little cuffs that go on the leg. They blow up and put pressure on the leg, and then they release. Remember, the point is so that the blood is not sitting in the legs and pooling. And it promotes venous return. So it promotes the veins to push that blood back towards the heart so that it doesn't sit there stagnant and then increase that risk for clotting, right? So it's used to promote circulation. It is not 100% effective, but it does do a great job at lowering the risk. So even with SCDs, patients can still develop thrombi. So it is still important to assess for that, even if they have those SCDs on, okay? We need to make sure that when we have patients who are on this machine that we are ensuring their safety from falls, especially if they're ambulatory. So we want to make sure that they either know how to take them off themselves. If they're confused, we want to make sure that they are calling for help, because if they get up and try to walk to the bathroom, if they forget these things are on their legs, they're going to trip and fall because they're attached to the bed, so to speak. And then putting this on and taking them off can be delegated to an unlicensed assistive personnel. So other ways to prevent these postoperative complications: incentive spirometry, deep breathing, and coughing. So you can tell your patient to deep breathe and cough all day long. That is going to help them. Turning and repositioning in bed will help them as well. That helps their lung function, helps them expand those lungs, which is what we need to prevent that atelectasis. But performing that incentive spirometer, which I'll show you a picture of here in just a second, is going to promote those alveoli with expanding, preventing atelectasis, preventing pneumonia, and it is super, super important part of postoperative education. Promoting early ambulation. The sooner we can get these patients out of bed and moving, the better. Remember, early ambulation is tied to many, many great outcomes. So we're talking, it's going to prevent that constipation. It's going to help get everything moving, right? It's going to promote circulation. Remember, every time your leg muscles contract, it's going to promote that venous return back to the heart and prevent those blood clots, right? It's all connected. Okay, and then client teaching. If we need to do some teaching, now's a great time to do it as well once our patient's alert and awake and ready to be educated. And then here's just a few pictures. So in your upper right, you'll see these are those TED hose or those anti-embolism stockings, super, super tight on the patient. Again, the point is just to promote that venous return so the blood doesn't pool in the legs. And then you can see here off to the right-hand side on the top, that's your sequential compression devices or SCDs. You can see the cuffs on the legs attached to this little machine here. Down in the bottom right, you see a patient being ambulated. Super, super important to prevent complications. And then your incentive spirometer is actually down on the bottom right. And so you'll see there's some markings that's going to have numbers all the way up from the bottom to the top. It's got this little tube here, this blue tube, and then at the end of that blue tube is a little whitish clear mouthpiece. The patient will actually be instructed to put their mouth over the mouthpiece, and they actually breathe in with this. They do not breathe out. I've seen some people think that maybe they're supposed to breathe out. That's what people want to do. It actually is easier to breathe out than to breathe in, but we don't want them to breathe out. The point of this incentive spirometer is to take a very big, deep inhale so that those air sacs at the base of the lungs, those alveoli, are going to be inflated. As soon as we take a deep breath, those inflate. Once they inflate, they're harder to collapse, right? And when they collapse, we know that that causes atelectasis, which can cause that difficulty breathing, a fever, all those things. So typically the main orders that you're going to see with this incentive spirometry on the unit is going to be, they say do it about 10 times an hour, and then they'll give them a goal. So if you see on the face there where the little markings are, you can see the yellow piece. Typically we'll move that yellow piece to whatever their goal is and say, hey, you need to breathe in over 10 seconds to meet this little yellow marker that I've put here for you, and then you breathe out. Do that 10 times every hour, and that's what's going to help prevent that atelectasis. And your last clicker check here. So the nurse knows that the most important reason for controlling post-operative nausea and vomiting in the PACU is to what? A, prevent the patient from becoming dehydrated. B, prevent potential airway issues. C, prevent the surgical dressing from becoming soiled. Or D, prevent the patient from becoming upset. And the answer is B. So your priority nursing intervention for the nurse in a PACU is airway management. So controlling nausea and vomiting is going to prevent aspiration and ensure that that patient has a patent airway.